Yeah.
Okay. Hi, my name is Leah Ratner, and I am part of the Global Health Program here at Boston Children's Hospital. I also work with our Bridges Young Adult Program, and I work here in Ghana with Dr. Charles Dickens.
Hello, so my name is Charles Martin Dickens. I'm a pediatrician in the Konfanochi Teaching Hospital, the Department of Child Health, and I'm a senior resident in the infectious disease unit.
And it's HIV.
Yeah, so I mainly run the HIV clinic.
And we put a picture of us a few days ago doing our data collection for a study we're doing in Charles's clinic. Okay. So we have three main objectives today. We want to recognize and respect the colonial history of tropical medicine, to give you some broad understanding of some common tropical diseases and their presentations in pediatric patients, and to recognize some context-specific best practices for treatment of a variety of neglected tropical diseases in pediatric populations. So a little disclaimer, this is not meant to be an ID talk. This is for non-ID trained clinicians. We want to highlight disparities in context-driven, so epidemiologically driven treatment approaches in endemic areas versus difference in like expats returning from travel. And as Charles really pointed out to me when we were making this presentation, that many of these diseases are treated with mass drug administration from a public health perspective by deworming rather than trying to get diagnostic specificity as we often try to do in non-endemic areas.
Yes, and this has to do with the economics of it. It's really is easier getting the drugs and doing a mass drug administration rather than the laboratory investigations. So in a resource limited setting such as you usually find in our part of the world, it actually makes more sense in this regard.
So just a quick little review of tropical medicine and recognizing that the history and ongoing legacy of it being a colonial tool. So medicine constituted a tool of the colonial empire. There is this quote that I pulled from Sir Ronald Ross after he took an expedition to Sierra Leone. In the coming century, the success of imperialism will depend largely upon the success of the microscope, meaning that they were able to conquer more land if they were able to understand tropical medicine, which was largely the impetus for these early investigations. There was their geographical context allowed for sanitation to promote lots of different types of segregation, as we still hear today when we think about the London School of Tropical Medicine and Hygiene. A Nobel laureate that was of the same era of Sir Ronald Ross, Dr. Kipling, described it as the white man's burden to introduce modernity and civilized governance in the colonies. And by controlling people as well as countries, these conquests turned medicine into a weapon in which to secure this imperial rule. And this picture here is simply that with cholera in India in 1984. And so just sort of to recognize the history of tropical medicine to try to help think about it from a decolonized lens.
Okay, so we'll talk about some risk factors for parasitic infections in children. So, of course, parasitic infections occur more in the tropical and subtropical part of the world, and there's a high prevalence because of the warm, moist climate we have, for sanitation, and the relatively low socioeconomic status and challenges with nutrition. And children are more frequently infected because of the very oral behavior they have, putting everything they can find in their mouth, and the inability to ward off bite by the arthropod vectors. So when we come to neglected tropical diseases, they span a wide variety from viruses, protozoa, bacteria. We'll be focusing on the helminthic infections, or the cestodes, the nematodes, and the trematodes. Slide. So common clinical presentations of parasitic infections include, as you can see, hepatosplenomegaly, lymphadenopathy, anemia, and dysentery.
Now we're gonna play Let's Name That Parasite. Welcome.
What do we win?
Yeah, I don't know. Chocolate. Goes well with parasites.
Yeah.
All right, so who can name this? And feel free to stop the video. Who am I? I'll give you a few seconds to pause. That's right. Hopefully you got it.
So this is the Ascaris lumbricoides. It's the largest nematode parasites in the human intestine, having a lifespan of up to 2 years. The adults are cylindrical in shape, usually white in color. Females are larger than the males, and you can see the curled tail in the pesicle-like copulatory spine, which is very typical of the males. So, of course, unless you have another one to compare, you wouldn't know which one is smaller. So that is what would give it away.
I will say this is a common exam question, isn't it? I've seen this on exams before, yeah.
Okay, so with the life cycle of it, of course, we always have to remember that the adults are in the intestine. So you find both male and female adults in the intestine, and they'll come out in fecal matter, and with the challenges of sanitation, contaminate soil. And it's the fertilized and infertilized eggs that are at the diagnosis stage. So it's by looking in stool samples, and then that's when you see these. And they go through a number of stages. So you become an embryonated egg, which is then ingested. And then this goes into your small intestines and migrates into your lung, puffed up and swallowed for the maturation to occur in the small intestine, and then the life cycle just continues.
So here's a picture of the egg under the microscope, and then these are the adult ones.
Yeah. So the pathogenesis and clinical features, we have to remember the pulmonary ascariasis, that's the blood-lung migration phase of the larvae, leads to allergic reaction. So you find eosinophils, macrophages, and epithelioid cells, leading to the pneumonia, as you can see the motile lung infiltration on the chest x-rays. And then you find what most people would think the kids have asthma by hearing the bronchi auscultations. Urticaria, so they are scratching all over. And as we previously said, eosinophils in blood. So the Loeffler syndrome, which is another common examination question.
Yes, it is.
But it's almost never demonstrated, is the fact that you have the pneumonitis and you can find the larvae in gastric washings or sputum, with the third component being the eosinophilia.
And remind me, it's hard to demonstrate because it happens so quickly. The pneumonitis, you're not usually symptomatic by the time it happens, yeah. But it's a good exam question.
So treatment, diagnosis, as I said, is by finding, demonstrating the egg and feces. And albendazole 400 milligram for those above 2 years is the standard treatment in our part of the world, 200 milligram for those less than 2 years. Other options are mebendazole, 100 milligram twice a day for 3 days, or 500 milligram start. Then parental palm weight, 11 milligram per kg. Iron supplementations and transfusion, of course, if indicated. And prevention is always better than cure. It's not always successfully so, but yeah, so proper disposal of excreta, shoes. So we know that it's not only the oral ingestion that causes these roundworm infestation, but Necata americanus, for example, enters through your upper extremities and torso. So kids are playing in soil at risk, and the ankylostoma duodenale is also orally infective as well.
So shoes are important.
Don't go barefoot.
Yeah. Okay, next one. Who am I? Give a pause for people to break and think. Hopefully get some chocolate.
Yeah. Take a drink.
Okay, so we're Strongyloides stercoralis. So Strongyloides, often referred to as strongy, is a nematode, as Charles, I think, mentioned earlier. It's very ubiquitous. In fact, I think it's the most ubiquitous nematode. And it's usually asymptomatic, which is why this one can be quite pesky, because it's not until later does it become problematic. It has a very complex life cycle. And the exam question is always that it's one that can have auto-infection. So and this is why it lasts for so long, because it self-infects once it's in you. So an acute strongyloidiasis is usually asymptomatic. If anything, you may see some like pruritic rash, and that usually is the larva migrans. And then it will sort of travel the same pattern as Loeffler syndrome, tracheal irritation. You may have a little bit of a dry cough. Again, something most people don't even notice. And then to the lungs. Then it goes into, you swallow it as you're aspirating, and it goes into the GI tracts. And this is a very common presentation of dyspepsia or reflux, some maybe anorexia. And then it turns into a chronic infection, can still be asymptomatic or sort of GERD or this chronic sort of cutaneous larva migrans. So here's some pictures of the rash. This is the worm under the microscope. And then here are some pictures of the pulmonary infiltrations. Anything else to add with that?
No.
So here, the life cycle, as we mentioned, it is a bit complex. So I just want to point out, first of all, the diagnostic stage is the rubidiform larvae, and that's what's excreted in the intestine, though it is hard to isolate. And then the infective stage, as we mentioned, is the filariform larvae, and that penetrates intact skin of the definitive host. So the other important thing, again, is that there's autoinfection, which you can see here. And so that once the eggs are in the intestinal mucosa, they can auto-infect from the large intestine, they become filariform, and then they penetrate the intestinal mucosa and then migrate to the other organs. Dogs can also be definitive hosts, which can perpetuate the cycle. So here I just thought this was a good graphic of sort of showing that strongy can be incredibly ubiquitous. It's very easy to treat, but it can cause a lot of damage. And so it's important to understand when it needs to be treated. The autoinfection, I think, is the most critical part of that. So just the risk factors, obviously, we talked already about contact with soil and how that can penetrate. But things that we don't think about as much, human T cell lymphocytic virus 1, otherwise, did you know that Mr. T was the one who had that? I always like that fact. But it's a common virus, retrovirus in the tropics, and it is a huge risk factor because of the T cell inhibition for strongyloides dissemination, which we'll talk about in a second. Steroid and immunosuppressive therapy is also a huge risk factor for hyperinfection syndrome, which we'll talk about in a second. And as we were talking about when we were making this, it's like very important to think about if there's any risk of strongyloides at all ever before you get on steroids for asthma or transplant or any other sort of autoimmune condition, to make sure you test and treat or just treat. And also like high risk populations in general, institutionalized populations. Anything else to add from this one? Okay, so I just wanted to make a point of hyperinfection syndrome. I know one of my mentors in residency like really grilled this into me because it's a commonly missed with, especially in the US with pre-transplant evaluations, because we forget that of all the people that have been exposed to strongyloides worldwide, it's such an easy thing to treat, and then we immunosuppress them, and now they have hyperinfection syndrome, which is a huge morbidity. So it's hyperinfection syndrome is usually a morbidity to the GI and pulmonary, and then disseminated strongy is usually a solid organ invasion. So it's usually when patients have sort of chronic strongyloides, they may have been asymptomatic, and now they suddenly receive high-dose corticosteroids. That's the most common, but other high-dose T-cell immunosuppressant agents can also be shown to do this. So I put a little bit of the immunology here on the right side. Essentially, it affects your CD4 and Th2 helper cells because of the steroid receptor, which causes increased apoptosis and more T cell dysfunction, which then causes the altered immunity and causes this hyperinfection syndrome, and really just spreads everywhere. Again, very preventable, and just make sure that you're screening for strongy for your patients that are return travelers in the US, and also when you're globally before you start steroids. So again, this is the take home. I think it was drilled into me so much in residency that I felt like I had to make a whole slide because it's so ubiquitous. And I thought it was funny because 1 dose of ivermectin for the win. Ivermectin's got a lot of bad press recently, but this is when you should use it. So I just wanted to add this in there. Okay, who am I? Chocolates for everyone. I'll give a little pause.
We are going to go into our filarial worms, consisting of the Wuchereria, Bancrofti, Brugia malayi, Onchocerca volvulus, Loa Loa, and the Mansoli.
And then, should I say, these pictures I think are really helpful because when you're telling them under the microscope, there's this little trick that I learned is that there's two ways to tell. One, if they have an extra, the extra little bit over here. So you see how there's a tail here and then the eye. That's how you always can tell Brugia. And then if they don't go all the way to the tail, for example, if the nuclei don't go all the way to the tail, like Loa Loa, Manzanella ozardi, and Wuchereria, you can tell, like you just have, you memorize which has the extra envelope and which nuclei go to the tail, and you'll always be able to tell them apart. Also, Streptocerca always has a curve. And perstans and ozardi are not usually clinically significant. Yeah, exactly. Our big ones are Onchocerca, Wuchereria, Brugia, Loa Loa.
So, Onchocerca causes river blindness, of course, with the presentation of pruritus, maculopapular rash often on the trunk, dermatitis, normal ocular exams, and rarely do you find nodules on the skin. It's really common in West Africa, but I mean, if anyone is an expatriate here, could present a little later, after a year later. So with the skin snips, you will see scanty microfilaria, slit lump examination of the chambers of the eye. You find none in the anterior chamber. You may or may not have eosinophils, and your IgG will be positive for the antifilarial antigens. As you can see on the pictures there, of the skin snip and then the worm on the eye. As well as somebody with river blindness. Okay.
And what is the utility? So in US we do skin snips, but I think there's not much utility to do that here.
No, so we have mass drug administration. We know the districts with that have endemic onchocerciasis. So occasionally, I think once or twice a year, we go and do mass drug administration in those districts. Yeah.
The skin snips are painful and expensive.
Yeah.
And not necessary if it's endemic.
So with the treatment, your diethyl.
How do I check? Oh, it's recording again. Wait.